Good evening and welcome to all participants to our fourth edition of the Greater Petaling City-wide Capacity Strengthening of MDT Management in Breast Cancer. So as introduction, my name is Dr. Teoh Ying. I'm one of the breast oncoplastic surgeon from University Malaya Medical Centre. And thank you very much for this opportunity to become the moderator for tonight. So this meeting is held in support of the Global Breast Cancer Initiative Implementation Framework by the WHO, emphasizing on the three pillars in achieving early detection and management of breast cancer, namely the health promotion for early detection, the timely breast diagnostics, and the comprehensive breast cancer management. So we are at this fourth episodes of our MDT, and today we'll be focusing mainly on the third pillar, which is the comprehensive breast cancer management. So today we will be focusing on this, and we are pleased to have actually the presence of Dr. Kavitha Däster, all the way from Switzerland, even though online. Okay, and also Dr. Nurulhati here to share her experience about Greater Petaling City and also the MDT that we have held for the past few episodes. So as before, just a brief introduction to the rest of the participants. This meeting is usually led by the spoke hospital from the public sector, with the presence of the experts from their hub hospital. So for today's episode, we will have a representative who is a general surgeon from Hospital Serdang, discussing a case on breast cancer with the breast surgeon, the oncologist and radiologist from UKM Medical Centre. So let's start our program with the introduction by Professor Dr. Nurulhati regarding the Greater Petaling City Cancer Challenge. So let me introduce Prof. Aisha briefly. She's our consultant breast surgeon from UMMC as well. And she's also the head of the Cancer Research Institute, and currently the lead person in City Cancer Challenge since 2019. She's also active in the project called Rebong, which is to reduce the barriers in cancer, early diagnosis in the urban B40 group. And her special interest is among genetic screening as well as quality improvement projects. So over to you, Prof. Aisha, for the introduction of this Greater Petaling.
Thank you, Dr. Teoh. So welcome again. I think this is the fifth installation of 6 installations of the phase 1 of the sustainable action plans that has been born from the first action plan of this Greater Petaling City Cancer Challenge. So the Greater Petaling City Cancer Challenge is a global movement of cities, and Greater Petaling, i.e. the Klang Valley, is the 9th city globally that is going to reduce inequality and improve access to quality cancer care in our city. So this action plan that was born and funded by the Islamic Development Bank and IAEA in 2020 have born this program, which we are actually implementing this year, which is the phase 1, where we are doing educational MDTs across the city to educate people about quality care in cancer, especially breast cancer. So what will happen in the phase 2 is that we will be disseminating the Malaysian clinical practice guidelines as well as the implementation of MDT best practice document across the city through service MDTs that will happen across the public sector anyway. So do keep in touch with us, because we will be hoping to carry on this program for the next few years. So don't expect it to end this year. It will have a more realistic service-oriented MDTs that we hope to implement in most of the public hospitals, because we need to support each other. Not all hospitals will have all the multidisciplinary teams. We will need to land on each other's resources to be able to deliver quality care for our patients in the Greater Petaling area. So that's all from me, Lee. So looking forward to today's discussion. Very important, I think. Dr. Kavitha is our Malaysian, well, she will tell us more about herself, I think, later on. And we hope to co-create many things together to improve quality in our city and hopefully in Malaysia. Thank you, Lee.
Thank you, Prof. Right. And like I said, we are honored to have actually Dr. Kavitha Däster here with us tonight. to share her experience on the breast cancer quality audits in the European healthcare setting. So I was looking through Kavitha's CV. It was a rather long one. All right, so I hope that I summarized it correctly. So Dr. Kavitha is our consultant breast oncoplastic surgeon from the Breast Centre Hospital in Zurich, Switzerland. She was a fellow in oncoplastic breast surgery and a research fellow in the Institute of Pathology from University of Basel from 2020 to 2021. And prior to that, she was a postgraduate fellow from the Westmead Breast Cancer Institute. That was up to 2020, and currently she's one of the council member of Breast Surgery International. So our honor to have you here tonight. Over to you, please, Dr. Kavitha.
Thank you very much. I'll just share my screen. Let's have a look. Is it clear? Can you all see it? Perfect. So thank you very much for the fantastic introduction. And I also want to thank Professor Aisha for this opportunity and honor to present at this meeting today. I'm very grateful. So good evening and selamat petang to everyone. As everyone knows, I am Malaysian. I was born in Malaysia. I trained in England, completed my general surgical training in England, and followed by a postgraduate oncoplastic fellowship in Sydney, Australia, and then moved over to Switzerland, and now I'm a practicing senior oncoplastic surgeon in Brustcentrum Zurich in Switzerland. So Breast Cancer Quality Audit, the European Experience is the title of my presentation today. So this is an overview of my presentation today. The one thing that we all know is that breast cancer quality audits play a very vital role in medicine. It certainly is a very important way of enhancing patient care. Now, what stems from the breast cancer quality audits is actually having an integrated breast care pathway. And I think this is essentially key before you go on to perform an audit on the entire patient journey process. So this is a project I worked on with actually in our breast center in Zurich to create an integrated breast care pathway offered to patients. So this is essentially a summary of what each patient goes through the entire journey, ranging from the the time the patient's referred all the way up to aftercare. But essentially, it can be broken down to three main areas. And I think that's first very important to know before you go on to perform an audit. So the structure and the facilities of every breast unit, the patient management process, and that includes screening, diagnosis, and patient treatment. And last but not least, patient outcomes. And essentially, the aim to perform these audits are to increase the quality of care of the patient. You want to enhance efficiency of the entire patient management process, and of course, improve patient satisfactions and outcomes. Now, to perform an audit, you really need to have a basic standard. So the standards that we use, or the guidelines that we use in Europe, is the ESMO guidelines for early breast cancer. You also have guidelines for metastatic cancer. In terms of structure and facilities for every breast unit, the EUSOMA European Working Group in 2019 produced a very detailed document on the requirements for a certified breast cancer unit. Now, this, I think a lot of centers in Europe certainly aim to fulfill these criteria, but certainly is very challenging due to financial constraints. But that's certainly the aim for most certified breast cancer units. You have the NCCN guidelines, which is somewhat similar to the ESMO guidelines, but it's basically put into a logarithm, which allows people to read it quite easily, and you can follow it quite easily. But what we have in Europe here is you have a lot of countries in Europe, all with different cultures, patient cultures, practice cultures, and different languages. So each country actually will have a national guideline. So in Switzerland, I live in the German-speaking part of Switzerland, and here we follow the S3 Leitlinie Mama-Katz. That's the German guidelines. And certainly, having trained in England, we are well versed with the NICE guidelines. In Scotland, the SIGN guidelines, and in England, you have the ABS guidelines, which is our the Association of Breast Surgery, the National Breast Surgical Association in England, and of course the screening guidelines, so NHS-BSP guidelines. Now, using these guidelines, a lot of national audits have actually been produced to assess the quality of breast cancer management. So I'm now going to give you a few examples of national audits that took place. I have to say UK is definitely at the forefront in Europe in terms of breast cancer quality audits. It's something we're encouraged very early on as a medical student and also as a junior doctor, and certainly at a much higher level of our training to perform audits regularly. So in 2011, this was one of the big game changer audits in England. In 2011, I was a junior trainee. And basically, the publication for the National Mastectomy and Reconstruction Audit came through. Now, here they looked at, it involved a significant number of trusts, not just NHS trusts, but also the private sector in Wales and Scotland, and recruited about 16,000 women. All these women underwent mastectomies, and they looked, the focus of this study was actually patient outcome. And so what they did find was the overall patient satisfaction was very good in the UK in terms of the clinical team satisfaction, consultant satisfaction, and overall care within the hospital. And this is I've summarized the information here from the audit, I think, and what's quite interesting here, you can see the blue graph is after a simple mastectomy, the red is after an immediate breast reconstruction, and the gray is delayed breast reconstruction. And they looked at different parameters, which include aesthetic and also functional parameters. And when this publication came out, the emphasis was really not to compare the different treatment modalities, but actually to use this information in your consenting process. So certainly from a daily practice perspective, this was definitely for us a significant influence, our practice significantly, because when we started counseling patients for mastectomies and in terms of what options you had for reconstruction or not to reconstruct, the information that we received from this audit was incorporated into our daily practice. Now, the next audit I've summarized here is from the Netherlands. Now, in the Netherlands, they have actually quite a very standardized practice across all the different hospitals in Netherlands. They have a national database, which puts them really at a huge advantage of producing national-based audits. So certainly for breast cancer, they audited their practice from 2011 to 2014, and they looked at almost 50,000 invasive cancers and over 7,000 DCIS patients. So what they found in their practice in Netherlands is that over time, MDT involvement improved, and certainly that's something we're seeing more and more in Europe, where a lot of countries now, the MDTs become a mandatory part of breast cancer management. They overall had low re-resection of margins rates. But what was interesting is they couldn't explain why they had a variation for the use of MRI scans prior to surgery for operative planning, and also the immediate breast reconstruction rates were different. But I think they published, their publication was in 2016. Certainly having a very extensive database, they managed to get through. They managed to publish quite a high volume of patients in their audit. Now, coming on to the next very important part of breast cancer quality audits is from the UK NHS breast screening program, so the UK NHS BSP. Now, the UK NHS BSP started in 1988. That's when the screening program started in England. And from 2000, they collaborated efforts with the Association of Breast Surgery and published a document every year from then on. So it's all accessible, free for everyone. That's the link down there. So essentially, they looked at the quality of the patients being screened and how they were managed, at disease factors, and also the treatment offered, but also survival analysis. So these are all the different parameters here. I've highlighted what was assessed every year. And I just have a little summary table here from what they found last year. But this is the total cancer. So they screened over 1 million women, and they found about 12,000 breast cancers. And this was in 2020 to 2021. But what's quite interesting is if you compare to 2019, well, the amount of women screened was about 1 million less. And I guess most of you can guess why less women were screened at this time. COVID hit the whole world, and women weren't presenting to screening to the screening centers. And they also picked up less cancers as well. So in 2021, they picked up about 14,000 cancers, 12,000 cancers, but normally they pick up about 17,000 cancers. Now, using the breast screening data, so the breast screening data is essentially published, and using all this data, a audit was performed called the UK Sloan Project. Now, what they looked at is they looked at these patients with purely DCIS, looking at what treatment they received, and following the treatment, what was their risk of recurrence. Now, this is a very important part of our practice. Certainly was in England, and I still use all this information for my day-to-day practice in Switzerland, because a very common question you get from your patient is, well, if I have pre-cancer and you've removed it, I don't need any more treatment because I never had cancer. And I think that's where this data comes into play, where you explain to the patients the risk of having ipsilateral breast recurrence, either DCIS or cancer recurrence. For what was the risk is significantly more if the patients do not receive radiotherapy. Certainly, there's more evidence coming through endocrine therapy, and the UK Sloan Project makes a comment to that. It wasn't a significant difference, but there was a non-significant trend. But I think to highlight that using the data from the breast screening, they developed this retrospective project, the UK Sloan Project. The data was collected prospectively, analyzed retrospectively, and came up with very good information that really influenced day-to-day practice. Now, this was an audit that I was actually involved in because I was a senior trainee at this point. So it was the implant-based reconstruction audit in the UK, and it really was used to assess the practice of implant reconstruction in the UK and to evaluate clinical and patient-reported outcomes. Now, every unit or most units in England were encouraged to participate, but in total 81 units participated, and every trainee had the role to contribute data. And I think that's where I think as a trainee, if you have the opportunity to contribute to national audits, it's certainly a very good way to help your unit be represented in these publications. So certainly you feel that then your unit is also, the data here applies to your patients. But what was very interesting in this audit is they actually showed that the post-operative complication rates were much, much higher than anticipated. So documenting an implant loss rate at 9%, readmission and return to theatre rate 18%, and infection rate 25%. And in the UK, the standard that you're looking for is less than 5% reoperation rate and less than 10% in implant loss rate for infection. So you can see that the UK, the IBRA audit basically showed that in the UK, implant-based reconstructions were not hitting the target. So what was generated after this audit was basically a proposal for a prospective study, but also for the best clinical practices for each unit had to revisit the best clinical practice in terms of implant reconstruction. And I think the next phase, they really were looking at assessing each hospital trust and seeing if there's anything they can do to try to improve or try to reduce the risk of implant reconstructions. Now, the last audit I've included here is a very recent one and it's currently sort of highly debated, is the management of breast cancer in older women. What we do know is that older patients are very poorly represented in lots of studies. And the big question is, are they receiving optimal care compared to patients who are younger? So in 2022, this was a publication, the annual report from the National Audit for Breast Cancer in Older Patients, really aiming to evaluate the care and outcomes of women over the age of 70. So the data was collected from 2014 to 2020, and they included data for all women over the age of 50 as a comparison group. So 50 to 69 was the comparison group. And essentially what they showed is over time, patients over the age of 80 with mild to moderate frailty had increased surgical treatment, which is what actually we're aiming to do. If the patient's not frail enough, then we really ideally would like to operate. That includes the ER-positive cancers. What they did show is that the radiotherapy usage in these women definitely reduced over time, and that's certainly consistent with the NICE guidelines, because patients who have low risk of recurrence, we are actually allowed to avoid radiotherapy in these patients. We also see an improved usage of chemotherapy over the years as well for patients with ER-negative and HER2-positive cancers, which is again consistent really with the current guidelines. What was quite interesting is I think that the DCIS patients in women over the age of 80 were actually getting increasingly operated on, which was quite an interesting fact, because that could be, you could debate otherwise, but that's certainly what we saw from this audit. Now, the one thing to say is that the variation across Europe is significant. So this is a very good study done by Mace Cabello, and they looked at the quality indicators for breast cancer across Europe. And what was very surprising to see is that if you want to perform a national quality audit, you need to have an integrated breast care pathway. But majority of countries in Europe, that includes Switzerland, we do not have a national integrated breast care pathway, which is why a lot of these countries don't produce any national reports or outcomes or publications on breast cancer quality audits. So just to emphasize, the variability across Europe is significant, and that's something I definitely experience as well working here. So in conclusion, yes, as I mentioned, significant variation across Europe. The key of actually producing a high quality breast cancer audit is to establish a clinical pathway first. And but what is clear is with breast cancer quality audits, you can improve the adherence to cancer guidelines and improve patient outcome and quality of care. Now, what is I think certainly important is the different types of audits. All of them play a very important role. That includes national audits, which I've presented here today, but we mustn't forget you have regional hospital audits, and also auditing yourself on an individual basis is extremely important as a surgeon, something that we were really encouraged as junior and senior trainees, and also as consultants, that you want to self-audit yourself and look at what your complications rates are, what's your resectional margin rates are, because that's how you can actually improve the patient that's sitting in front of you. And just food for thought, because one person can really make a difference. I know most of you here have a general surgical background, so you know what the mesorectal plane is. Now, Professor Bill Heald worked in a district general hospital not even in London, in Basingstoke, so far away from London. And what he did in 1982, he performed a self-audit on all the patients that he performed rectal cancer surgery on. And what he noticed was when he followed the mesorectal plane, the risk of pelvic recurrence was less. And this led to his publication, which, according to my husband, who's a colorectal surgeon, is the most cited publication in medicine. And basically was a huge game changer for rectal cancer surgery. So he's the father of rectal cancer surgery, but that all stemmed from self-auditing his practice because he wanted to improve his practice for his patients in a small district general hospital. So one person can make a difference. So I strongly encourage that the whole auditing process also takes place, just, starts with yourself. Just very quickly, just want to talk about breast fellowships. In Europe, breast surgical fellowships, there are a lot of different fellowships across the different countries. So it's very country dependent. In Europe, most countries have it trainee-led or initiated. So you go through training. You don't have to undertake a fellowship to proceed on to work as oncoplastic breast surgeons. But a lot of trainees, certainly in the UK, they do take on a fellowship. Now, where you do your fellowship is very variable. So the quality is variable, the hands-on opportunity is variable. So I think it's really important to first know what you're looking for before you go on to actually identify a unit that can give you what you're actually seeking out to achieve. In the UK, you have the National TIG Fellowship, but as far as I know, I believe that's only open to UK trainees who've completed their training. But as an international trainee, you can apply for the ISTP program, the IST program. But I believe you won't be able to choose exactly what center you want to go to that's allocated to you. But I think what's quite valuable are the local fellowships, that if you speak to people and you find out there's a good unit where there's a good trainer offering exactly what you're looking for, either basic oncological procedures, oncoplastic procedures, focusing on reconstruction or lipofilling, then you can actually apply directly to the hospital. And a lot of the local fellowships, you can actually try to get funding for it as well. So they actually pay you to be part of the team. I strongly encourage towards the end of the fellowship, you do a formal qualification. And one of it is the fellowship of the European Board of Surgery. So they have a breast fellowship qualification. It's an examination that's a written examination followed by a viva examination about 3 months later. Strongly recommend undertaking that as a formal qualification, but towards the end of the fellowship. Thank you very much.
Thank you once again to Dr. Kavitha. A very, very comprehensive talk on audit. And actually, I have one short question before we start our case discussion. So I'm actually quite impressed with the figures that you have collected for the patient-related outcome. So did you go through a specific designated nurse, or is there a specific staff that helps out in collecting all this data? During each follow-up, like what you mentioned earlier.
Do you mean the current prospective study we are undertaking at the moment?
Yes, the one you mentioned at certain period of time, like after 6 months and a year.
Yes, very tiny. So at Zurich Breast Centre, we have a dedicated research team. And what we do is, so once you've consented the patients and this information is incorporated into a database, at every interval, the research team checks when the patient's coming back, and the medical practitioners who basically they're at the front desk, so they get given the questionnaires, and we get given the questionnaires, passed it on to us, so we pass it on to the patient. I have I'm basically I have a master's student working with me, and that's how we started the project. So then we applied for ethics through because she's doing her master's with me, and I think she'll come back to do her doctorate thesis with me. To do a long-term follow-up. So she's now collecting all the data. But a lot of things is, yes, it's very challenging, definitely. So what I try to do is I basically offer my colleagues and say, don't worry, you'll be part of the paper. You do a little bit of work for it. So it's a little bit of encouragement. Colleagues so they know that if they recruit the patients, the key is they just need to get the consenting done, because once the consenting is done, then we are we can contact the patients directly. If there's any misinformation, we can send out questionnaires again. But the key is the consenting. The key is actually to approach the patient first. I think that's where my colleagues. So I've approached most of my colleagues are all gynecologists, because in Switzerland the gynecologists perform breast operations, and the head of the unit is a surgeon like me. So everyone consents their own patient.
Okay, great to hear that. And we hope to probably have a future collaboration too.
Yes.
Okay, thank you. So without further ado, let's kickstart our case discussion for today. So for the next 40 minutes, we will have one case prepared by our general surgeon, Dr. Nurulhati Ghani. I think she's here with us now. So she is our general surgeon from Hospital Sultan Idris Shah, also known as the Serdang Hospital. And she's a general surgeon graduated from HUKM, which is UKM Medical Centre, in 2017. And she's now in Serdang Hospital until present day. So for the list of our panelists, we have Dr. Kavitha herself, right? As well as we're honoured to have Associate Professor Dr. Nani Harlina, BTI Latar, who is a consultant breast and endocrine surgeon from the UKM Medical Centre. And she obtained her specialization in surgery in 2008, as well as obtaining her PhD in genetics from the University of Newcastle in 2018. So here with us today as well is Dr. Noor Faiza Muin, who is the clinical oncologist from the same centre, UKM Medical Centre. And our fourth panelist is Dr. Aida-Widure Mustapha, PT Muhammad Mustapha, who is our consultant radiologist, also from the UKM Medical Centre. So this will be carried out as a case presentation, and we shall discuss on pertinent issues as we go along the case. All right, over to you, Dr. Hati. I think you're still muted, Dr. Hati. We can't hear you. Right.
Hello. Hi, good evening.
Hello, good evening. Would you like to share your slides with us?
Okay, all right. Anyone can see?
Good to go.
Okay. Hi, good evening, everybody. I'm Dr. Nurulhati from Hospital Serdang. I will present a topic on metastatic breast cancer. This is Madam MK, 63-year-old lady. She has no medical illness and ECOG 0. In June 2019, she first presented to our center with right breast lump for 3 months duration. However, it was painless, no skin changes, with no axillary swelling. She menarche at age 13, menopause at 53. She was para 3 with first childbirth age 19 and breastfed total 2 years for each child. And OCP history of OCP use for 3 years. Family history, her sister passed away from breast cancer. She is non-smoker. On clinical examination, there is a right breast lump, 3 by 3 centimeter mobile. However, there is no skin changes. With the single palpable right axillary nodes, 1 by 1 cm, firm and mobile. The lump was at the lower inner quadrant, near to the nipple areola complex. From there, we proceed with imaging, mammogram and ultrasound in August 2019. However, I am unable to trace the mammogram image. And here is the ultrasound image.
Maybe at this juncture, is there any comment from Dr. Aida, perhaps? If there's none, is there any questions from the panelists? May I just ask the question of whether you know how old was the sister when she passed away due to breast cancer? Is there any information on that?
Sorry, we didn't manage to go back to the history to get the age of the sister that time.
Right, sure.
Sorry, would you like me to comment on these ultrasound images?
Yes, if you can.
Okay. Miss Hati, do you think you can give me request remote control, because then I can use my pointer? Can you? Okay. All right.
Sure, done.
Okay. Can you see my mouse moving? No.
Yes. Yes.
Oh, okay. So on the first image on the left-hand side, there is a very multilobulated lesion, which is very hypoechoic relative to the surrounding tissue. And here, I don't know whether I can convince you all, is actually the nipple. So it's quite close, but not really touching the nipple at this juncture. And the tissue above this lesion is rather like effaced or compacted. That's why it appears a bit more hyperechogenic compared to the rest. And the size of this lesion is about 2 by 2 centimeters in diameter. And on the color signal, it does show vascularity. Moving on to the axillary region in the right side, there are at least 2 abnormal lymph nodes that they saw. If you look here, where I'm pointing at, this is actually representing the cortical thickness, which is abnormal and increased. And here, which is relatively hyperechogenic, is actually the fatty hilum, which is significantly smaller. This is another lymph node that is showing measurements in long axis and short axis, which is already enlarged and abnormal. And you don't see the fatty hilum as well. On the last image on the right-hand lower corner is a retropectoral node. This is the pectoralis major muscle, and this is the pectoralis minor muscle, and there is a node in between it, but this node still appears normal, which has a sub-centimeter, and the cortical thickness is not increased. Thank you.
Thank you. Yes. Over to you again, Ms. Hati.
Okay. From there, we also proceeded this patient with another imaging, CT thoracic abdomen pelvis or staging. So I would like
Okay,
Dr. Aida to comment
it's me again. Sorry.
Sorry.
So these are axial images of a contrast enhanced CT scan. The primary tumor is shown here on the left upper corner, where it is enhancing, and it has very fine microlobulated margin, and this is the nipple. So you can see there is some distance between the lesion and the nipple, and also there is already surrounding perilesional fat zucchinas. Okay. Moving on to this image, there is already abnormal roundish axillary nodes which are enhancing and are enlarged. Further down, there are also more axillary nodes that we can see in the lower axillary region. And here, although it's not enlarged yet, but it's already starting to look abnormal, which is the right paratracheal node here shown on my cursor. This image I've put up here is to show that this particular small node, although it is small, it is already having a roundish appearance, and it is enhancing just right next to the lateral aspect of the pectoralis minor muscle here. So apart from that, there's no other, I think, abnormal findings in the rest of this patient, except for the bones. We can see there's a well-defined sclerotic lesion. If you look carefully, the margin is very well-defined. It does not have to, there is no cortical break that is caused by this lesion, and there is no what do you call it, and the transitional zone is very narrow. So in our impression at this time, it is a sclerotic region. It doesn't really have a direct malignant appearance. It does still appears to be equivocal, because usually a very large bone island can also appear like this. And can you see my pointer? I hope it's moving. Okay.
Now
So
yes.
okay. And other differentials that we can think of besides the bone island is a fully ossified, like for example, what do you call it? An ossifying fibroma. So at this juncture, it is leaning towards benign and not really particularly malignant looking. Okay. Okay, so these are set of axial images in the lung window for the same patient on the same study. Just by looking overall, you can already see scattered roundish lung nodules that is being pointed by my cursor. For example, here and
I think you
here.
lost it
So,
again.
oh, you lost
Switch
it.
it back.
I keep moving my here. Can you see there? There's one here at the peripheral aspect of the lung. Here, mostly peripheral, but they are roundish looking here in the lung bases here and here. So these to us are already suspicious of malignancy because they are scattered, they are round, and patient has a primary breast CA. So these are in keeping with lung metastasis. Okay, thank you.
So as shown, as described by Dr. Aida previously, mammogram and ultrasound showed BRAF 5 with the lung metastasis and suspicion and possible left acetabulum, but it's we lost patient for 1 month follow-up, but we managed to call her again for ultrasound guided biopsy in October 2019. But the HPE reported 1 month after, which showed invasive carcinoma of no special type, ER positive and ER positive with HER2 equivocal, supplementary FISH test non-amplified. So at this stage, she's right breast carcinoma, clinical T2, and one with mets to lungs. So at this time, patient not keen for surgery. She was started on endocrine therapy, letrozole, and then she remained 2 years disease-free and stable under 3 monthly follow-up until June 2021. In our follow-up in 2021 June, she had increased the breast size tumor with new skin erythematous region. On examination, right breast mass 6 by 6 cm with overlying skin erythema. However, still there is no discharge or any discharge from the nipple or any discharge from the breast mass. With still present the right axillary nodes 2 by 2 cm. However, the contralateral breast and axilla still normal.
So perhaps we should just pause for a while here, and
Sure.
maybe just direct the question to Dr. Faiza if she's with us. What's your opinion about? Yes, we have our Dr. Faiza around.
Yes, I'm here.
Hi. Right. Any opinion regarding the HPE and also the option of treatment?
I just would like to summarize what information we have now. This lady is a 63-year-old lady with diagnosis of metastatic breast cancer on the right side, which actually metastasis to the lung. So on the CT scan examination, I think it's quite, although it's small, it's quite suggestive of lung metastasis by the looks on the CT scan. So we have established the diagnosis. This is a stage 4 disease, so the intention of treatment is palliative. So for metastatic and the molecular and the biology of this tumor is strongly ER positive and HER2 negative. So in terms of treatment that we can offer as the first line metastatic breast cancer for this lady, for hormonal positive cancer, so we usually offer combination of hormonal therapy with CDK4/6 inhibitor. So she's post-menopausal, so normally we start with letrozole with CDK4/6 inhibitor, either palbociclib, ribociclib, or abemaciclib. So this patient was started on letrozole as a first line. I'm not sure what's happened, but normally in our setting, and it's in 2019, 2019 ribo CDK4/6 inhibitor is already in the market, but I think it's rather early in the years of this drug coming into Malaysia. The other issue is that maybe there is a cost issue, but as a standard of care, if patient can afford it, we will discuss. So the other issue to touch on is the cost of the medication. I think the cost of palbociclib is about 5,000 per month. There were some patient-assisted program, but it's still quite expensive to majority of nations standard. The other options we can offer ribociclib. Ribociclib costs about 3,000 plus per month. And then the other option is abemaciclib. It costs about 4,000 plus per month. So if you can appreciate if for Malaysians, that majority would have struggle in terms of accessing this medication. But if patient can afford, that's what we will suggest patient to have.
I think there's a comment from the floor that I think your voice sound a bit soft, but besides that, I think there's also a question from Dr. Mastura. When the ultrasound mammogram were done, on the finding of a suspicious finding, did the radiologist alert the surgeon about the biopsy recommendation? So maybe the presenter could offer the answer. Sorry, I think
Dr. Teoh.
yeah.
Quite late here. Sorry, what the question again, Dr.
Yeah,
Teoh?
there's a question in the chat box mentioning about whether the surgeon was alerted about the suspicious finding from the ultrasound mammogram.
Yes. Yeah, we alerted the suspicious on mammogram, the findings of ultrasound and mammogram. Yes. But then at that time we know it's a stage 4 disease, and then despite that we offered surgery for the small lump, but then patient declined for that. So she preferred to not having any operation yet. So that's why we embarked her on the endocrine therapy with letrozole. We oncologists have.
So that would answer the second question on whether mastectomy was actually considered. Am I right?
Yes.
Dr.
I've got a question actually.
Yes.
Teoh. Okay.
Yes.
Yeah, it's interesting. I think in the event of metastatic disease, we wouldn't normally offer surgery up front unless there was concern with with the fungating tumor or for local control. If there's concern in local control, we offer surgery up front. But if not, normally you start off with systemic treatment. As Dr. Faiza mentioned, yeah, we would give CDK6 inhibitor and endocrine therapy. Just a quick question for Dr. Faiza. With the sister's family history of breast cancer, would you consider either doing non-NGS testing for the primary cancer itself, or even genetic testing for the patient? Because if she did come back as a gene positive patient, then would she qualify for a PARP inhibitor?
I think this patient has she's diagnosed at she's 60 years old, right? So she's I think for our center we don't have okay, so to answer your question, I think this patient has a risk factor because she has breast cancer, and the other sibling has a breast cancer as well, and we should find out about the age of the siblings, and I think with the availability of treatment for someone with germline BRCA mutation, I would check for BRCA for this patient as well. Yep.
All right. Maybe we should just carry on with our discussion, and probably some other further questions brought up later.
Okay. I proceed. So because of the new changes into June 2021, we repeat the CT scan for this patient. CT staging again lah, thorax, abdomen, and pelvis. And Dr.
Oh, hi, it's me again.
Hi.
Okay, so these are again axial images from a contrast enhanced CT scan. If you look at the first image, yes, we see again the primary tumor, which is larger and already occurring little pockets of necrosis within, which is the non-enhancing part. But interestingly, if you look here, there is a new nodule which is enhancing at just underneath the skin and involving the subdermal tissue as well, which is a separate lesion. So I think this is the lesion that we saw on the clinical examination where it's kind of a bit red, okay? And the other slide, if you can see my cursor, this is actually the nipple here. So the lesion that was originally, if you remember the image before, had a bit of distance away from the nipple, but now it has already touching the nipple and causing how do you say, indentation onto the overlying skin. this third image is showing the originally much smaller lymph node, just lateral to the pectoralis minor muscle is larger, as well as the other lesions in the right axilla. Okay, and again we see the stable sclerotic lesion. So at this juncture, we are quite confident that this is a benign sclerotic bone lesion. But otherwise, there is disease progression compared to the previous CT in terms of increase in size and number of lesions in the right breast. I think that's the next page, next slide. Oh, is it me? I don't know. I don't know. Okay, sorry.
Okay, sure. So,
Tertinggal. Sorry.
this one is thorax, abdomen, this one is abdomen.
Yeah. Is
This
there
is thorax.
another slide after it? Oh, okay. So this one I don't
This
need to
thorax,
point, but you can clearly see that the numbers and sizes of the nodules that we saw earlier has increased in size and number. So this is again disease progression. Yeah, thank you.
Okay, sure. So we started her on, we started her on this one. Sorry, where?
There's one more slide after this.
Yeah. Previous. Yeah, because of reassessment of CT scan, because of the tumor progression in June 2021, we continued patient on letrozole with addition of palbociclib from August 2021 to January 2022. For which after that we reassess the patient with CT TAP again in January 2022. Despite having all that treatment, she still has disease progression, which showed larger primary tumor, increasing size with increased number of axillary nodes and worsening mediastinal nodes. At this stage, she was given palliative chemotherapy for 6 cycles from March 2022 until June 2022. This is the CT TAP reassessment after given letrozole and palbociclib.
So in this CECT, again, we see, I know you probably don't remember the size before, but trust me, the lesions are getting bigger. There is still, even though that is already causing extension to the skin, but there is no ulceration still seen, and this is the nipple here just next to the lesion underlying it. But this particular lesion that's just underneath the skin is also much larger, and there's more necrosis of the primary tumor in the right breast. And apart from that, there are also mediastinal nodes here, especially the left and right hilar nodes, which are larger compared to previous CT scans.
And this is CT thorax.
Would you like to complete your case first, Dr. Hati? Then we'll come back for the discussion.
Okay. And then we reassess again patient CT scan in July 2022 with the palliative chemotherapy. She showed slight good response with smaller primary tumor with improved nodes and lung metastasis. This is the reassessment CT staging with the palliative chemo. So at this stage, actually patient was offered surgery, however she still declined for that. So she was changed to tamoxifen in 2022. However, latest progression of this patient is in May 2023. She had new symptoms, which is forgetfulness for 1 month. The CT brain in May showed brain metastasis, and then she received the whole brain radiotherapy after that. Despite that, currently she is still asymptomatic, staying with children, ambulating without it. But she's still not. We didn't offer any surgery for her. we plan to start a semester, but then we haven't started. Yes.
Yeah, so
This is
these
the-
are contrast enhanced CT brain showing the enhancing brain metastasis with quite bad surrounding perilesional edema.
Yeah, so thank you very much to Dr. Hati for her case presentation. I think you have some questions to bring up from your hospital as well. Is that right, Dr. Hati?
Yeah, because actually if we go through this case, actually there are so many missing points here, even from the timeline of the treatment. First patient presented in June 2019, and then the image diagnostic only done in August, which is 2 months delay. Despite that, the biopsy core ultrasound guided only taken in October. So from first presentation in June until October is 4 months apart. This is itself the delay in diagnosis and management. But having said that, once we managed to get this, we managed to contact this patient again for our follow-up. We proceeded with co-biopsy, and then the HP will come back in 1 month's time. So that's the usual standard for HPE report. However, other than this, apart from that, we also have other issues lah from Hospital Serdang, because most of our cases for breast, actually we do not have any specialist, BNI specialist. So any complicated case or any case that we are unsure or any advanced disease for breast, we just call our neighbor friends there to in Hospital Putrajaya for support and opinion. Sometimes we just straight away refer there. So, however, having said that, the Hospital Putrajaya is first class hospital. Therefore, most of the patients cannot afford to go there due to financial constraints. Some of them just went to Hospital Putrajaya and then just to get the plans and management, and then come back to our hospital with the reply letter if they cannot afford the treatment there. So having said that, we also, as general surgeons, for most female patients, for breast surgery, we cannot offer the breast reconstruction in one settings. So if I were in charge in the breast clinic, if patients that I would say would benefit for the breast reconstruction with the same setting in the mastectomy, I would just straight away refer to any BNI center, not necessarily Hospital Putrajaya, but I will refer to any of my friends in BNI center, regardless Hospital University or HKL or any university or any as well in Selangor lah nearby. So
Yeah, I think,
also,
when we actually draw out the timeline, I was trying to catch up with your presentation and draw out the timeline. Indeed, like what you said, there's some sort of delay in the beginning of the presentation. So I think we always emphasize on the timely diagnosis. I mean, this is not a session to pinpoint the mistakes but we are learning from what we had seen. I mean, of course, there are certain cases that even we managed that came a little bit late as well. But I think it's wise to keep up with the timely diagnosis. So early referral to a healthcare center in 2 weeks, like what proposed by CPG, all right? And once we investigate, at least we have to commence on the treatment within 60 days. Am I right, Prof. Aisha?
yeah.
Sorry, I had to unmute. Yeah, so this we have to remember the WHO pillars actually gives a timeline of 60 days from the time of presentation to a hospital or clinic until the diagnosis is made. So that period of 60 days is actually between presentation to the clinic to the diagnosis. And the treatment, the start of treatment is usually, if you look at the literature, the medical literature, is actually about 30 days would be the best outcomes. And of course, anything beyond 60 days of starting treatment, the survival starts reducing for early breast cancer. So there are actually literature on that already. But if we reflect back on the WHO pillar of that 60 days, they actually have evidence to show that if you diagnose with beyond that 60 days, there would be some impact in the survival of the patient. So maybe in this case, we recognize, I think Dr. Hati, you're working in an acute general surgical practice, and it's difficult to manage pushing the system. May I ask, between the August and the June, was the difficulty actually getting the memo and ultrasound appointments? Was that why it was slightly delayed in terms of doing the triple assessment? Was that why the biopsy was even later than that?
Actually, for this patient, we after the image is done, we trace back the report, and then we lost the patient for follow-up for 1 month. That's the delay. However, we managed to call her again. We have our medical officers to call the patient. We managed to convince her to come to our follow-up again.
Yeah, I think we face the same thing. The issue sometimes is we have very expensive navigators, you know. Even in our unit, we have our medical officers calling patients, but this is the most expensive navigator, you know, the world has produced. We need MBBS and people training to be surgeons to actually become navigators. So maybe we should really rethink about how we get more cheaper support, regular cheaper support. But I know MOH, even your nurses are manning the counters, right? So it's very tough. You don't have admin support and all that. Maybe we can even ask Miss Kavitha, you know, how does it look like in Europe? Is this problem the same? Do people also face the same problems in other parts of the world?
Yeah, definitely in England we did. I think the house officers, which are the the junior doctors, have to do a lot of chasing patients, running around, things that are well beyond their pay grade. You definitely have that, but I think one of the key things that we have, which I'm sure you're basically pushing to start in Malaysia, is the the MDT. So you have the MDT coordinator, and the MDT coordinator is often someone not from a medical background. But they basically coordinate all the efforts of the patients that have been put into MDT. So a patient like her, you'd have seen a suspicious lesion, you'd have put it onto the MDT straight away. And from then on, the coordinator basically tries to tie all the loose ends together. So the coordinator brings all the different specialities into this. So I think that's where the efforts are better coordinated, when you have the MDT to actually help support all the doctors in the patient management, because sometimes you're just overloaded with patient load, and not one specific person or one specific doctor can actually manage all of it. So I think that's where it does help having the coordinator on board, or a breast scanner who is also part of the tumor board, MDT.
Yeah,
Yes.
I think this is also correctly pointed out by, I think, Dr. Mustapha in one of her comments, where actually she mentioned that maybe just one day in a week where the surgeons, I assume that you're mentioning the surgeon, can actually talk to the radiologist on doing the biopsy on the same day once the lump is known to be suspicious. And also the referral pathways is always a big headache in Malaysia, where to send, and that referral hospital to hospital sometimes takes time, for patients to actually visit the other hospital is also another headache. So I think that there's a lot of comments in the chat box, all right? So I'm trying to catch up with all the comments there, but meanwhile, maybe the panelists as well as the presenter can also go through. But I think there's one pertinent point that was brought up by Dr. Mustapha again, about considering a rebiopsy later when the patient did not actually turn out very well on the letrozole. So was there a recommendation for rebiopsy? And would you offer that? Maybe Dr. Faiza would be able to help.
I was about to point out, actually there's a few things I would like to point out from this case. Firstly, the upfront treatment, as we have discussed, should be standard of care, should be with CDK4/6 inhibitor. And this patient, if you see, she's on letrozole about 18 months. She progressed on letrozole, and she was put on CDK4/6 inhibitor after that with letrozole. So usually at this point of time when she progressed, because she progressed about 18 months, if I'm not mistaken. So at this junction, the options of treatment for her is either usually we change the endocrine backbone, and if she hasn't had the CDK4/6 inhibitor, you can add at this junction. So either to rebiopsy at this stage, there's an option, but I think in terms of treatment that she can offer at this junction, I think she's still quite sensitive to hormone, and I wouldn't, I'm not sure about others, I wouldn't push so much about rebiopsy, but after she progressed with addition of CDK4/6 inhibitor and maybe another change to another hormone like fulvestrant, something like that, and if she progressed, at that point of time I would suggest for rebiopsy to see whether there's any mutation that you can target, such as PIK3CA, or sometimes you can also send for ESR. Sorry, I didn't turn on my camera, I just realized. Or you can add, or you can test for ESR1 mutations, because I think this will help your subsequent treatment. The other things that I would like to comment in terms of oncological management is that after she progressed on CDK4/6 inhibitor, she was then put on chemotherapy, and she responded quite well in the primary as well as the metastatic area. So there was a discussion, I think in the chat box also, someone asked if she's stable at other places, would you offer mastectomy at that point of time? So I think this is a discussion to be made with patients, because when you see the CT scan, the tumor is actually when she progressed after the CDK4/6 inhibitor, CDK4/6 inhibitor, the lesion is quite big. So sometimes we do toilet mastectomy if either lesion is stable, because it will be really troublesome for most patients who has fungating breast mass. So this is something that we can discuss with patients and the surgeons. Yeah, and I think Dr. Mastura also point out about rebiopsy to see whether there's any other molecular targeting things that pathway that you can target. Nowadays we have, because this is HER2 negative patient, if he progress at a later line, there's options to add medication that target HER2 low. So that's an option. So usually nowadays we move to test all these molecular what we call characterize the molecular mutation that the patient have, so that we can target the treatment to this mutation that we have at hand. The other things that I would like to add in terms of oncological management is the brain metastasis. I think at this junction, we don't know how much the lesion is. Sometimes if it's multiple small lesion that we can target with advanced technique rather than whole brain radiotherapy, that is something to be discussed as well.
Yeah, thanks a lot to Dr. Faiza for her valuable comments. But I think quite a few comments commented on whether should we operate first or should we even operate on metastatic breast cancer. So maybe just get Dr. Nani and probably Dr. Kavitha to share the experience and what are your thoughts in those stable metastatic breast cancer. Maybe Prof. Nani, would you like to take the lead?
Thanks, Dr. Teoh. The thing is that we already know that there is no survival benefit in operating in patients with metastatic breast cancer. For us, usually most of the times, if it's not causing problems, for example, ulceration or the tumor causing a lot of symptoms, we don't actually normally offer surgery. And especially in this patient, if we really look back at the history, she's got like non-responding tumors, I would say. So we will be really careful in offering surgery unless if it's causing symptoms. So for example, like if the tumor did respond for quite some time, for example, 1 or 2 years, and it stays dormant, but the local disease is not, the local disease is causing problem, then yes, surgery might give benefit, but still not in terms of survival, but probably quality of life.
Yeah, I agree, Professor Nani. I think we would only perform surgery on her if there was an issue with local control. Otherwise, I think there's benefit to the patient. But I think in some patients with really stable disease or complete radiological response with metastatic disease, some of these patients do choose to have surgery. And again, we do emphasize there's no survival benefit for these patients, because then it comes into question, would you do just the breast, or would you do the breast and the axilla? Would you give them radiotherapy afterwards if you're not doing a mastectomy on them? Or if you do a mastectomy, would you do chest wall radiotherapy? So I think, yeah, it's quite a complex situation often, but we do operate on some patients with really stable disease. Like this Wednesday, I'm doing a mastectomy and a reconstruction on someone who's had 3 years of complete radiological response after CDK4/6 inhibitor and endocrine therapy. So a complete response, and she opted to have surgery. So
they're very individualized.
Yeah.
I think eventually it goes down to each individual, all right? So how bad is the local disease, and what's our aim, and also all this has to be discussed in the MDT level with the oncologist. So I think we are approaching the end of our case discussion, but I'm just trying to catch up with all the other questions I have not read yet. But the last question actually is something else. The question goes this way: would the oncologist team for this case, or any other cases for that matter, consider implementing psychological interventions or prehabilitation, which may possibly assist with treatment adherence and perhaps illness acceptance? So we're looking at the psychosocial aspect of these patients, on why patients, default in between the treatment, even before the diagnosis was actually told to the patient. So any support system in Hospital Serdang or maybe in UKM?
For Hospital Serdang, we don't have the psychology support, but then when the breaking of bad news still done by the surgeons itself.
Maybe introduction to the survivor group, if you have, would actually give the patient a little bit of idea, because I think some of our patients are quite lost with the diagnosis, and it's too overwhelming for them to be, having breast cancer. So maybe speaking to one of the survivors would actually help them in the process of the treatment as well. I know doctors, all of us are so busy in the clinic, we just come and tell them, okay, what you should do, and then that's it. You're not going to see them for the next probably few months later. So that's how I think some of our patients start to default their treatment, unfortunately. Right, any more questions from the panelists regarding this patient? Dr. Hati, do you have another slide to show actually? Sorry that I interrupted you in between.
Sorry. Oh, I think there's another slide I left. This is the last slide. But then the point here is that Hospital Serdang also having a close proximity to Hospital Kajang and Hospital Cyberjaya and some private hospital. Some of these patients actually defaulted from other hospital, just those nearby, but then come to our hospital for further opinion or second opinion. But when they come to our Hospital Serdang, they didn't bring together the previous workup. So this has caused us to start the workup again. For me, this is wasting of resources, where we need to repeat the imaging and the biopsy again. So I think this is something that we need to work up on with the make it more centralized, where patients should go, because so far if we have any referral from let's say nearby hospitals from Hospital Kajang or Hospital Cyberjaya, we just we just call back the respective hospital to get more information. However, sometimes it's so difficult, and then the paper lost. So sometimes we need to be more vigilant on this. So
right, and when you mention about hospital shopping, you have to include the private sector as well, because some patients, they shop even both the public and the private side. So that's when more delay would happen to the patient. So I think rightly mentioned by Dr. Vaishnavi also that there's always a huge discrepancy in the standards of care in the public and the private sector. So all this because of the imbalance of patient volume and resources. I think she mentioned about the waiting time of investigation, the workflow of diagnosis and treatment, everything will be actually affected. So all in all, I think I would like to just summarize from what we have learned today from this case. So number one, we realized that it's very important to actually comply to the timely diagnosis on when patient first presented to us and when we actually get the diagnosis, and then intervene correctly. All right, and the follow-up should be quite vigilant from the primary team. And MDT is always, I think, the most important thing in the management of this kind of patient, because everything we talk about is all individualized. So we talk about whether this patient should have neoadjuvant chemo first, or even mastectomy first, or trial of even immunotherapy. And thanks to Prof. Ho, mentioned that he's actually running also several trials, including the Teoh trial. So I think a note to those oncologists in this audience, take note of that. Okay. And refer to UMMC. So we open a lot of opportunities for the patient if this case is to be brought up in the MDT meeting. Even though we are far away in different hospitals, we can always link to each other using this kind of platform. For example, the Echo Zoom or Google Meet. Okay, so I know that it involves a lot of commitment and sacrifice, but I think whatever we do every day involves that as well. Okay, so any last words, perhaps from either Prof. Nani or Dr. Kavitha, and if not, then we shall wrap up the case soon. Dr. Kavitha?
No, just echo what you actually already said. Yes, that's a lack of standardization in the care, but I think as individual doctors, hopefully we can try to bring that all together and do whatever we can. And I'm sure the service will change over time. It's just a matter of time now as we bring all the expertise together in a MDT setting. It's just a matter of time for change.
Right. So I would like to thank everyone for your precious time, especially to our dear panelists and also Dr. Hati for sharing this case with us.
Just a quick question, Dr. Teoh.
Yes.
Towards the end of this session, for example, like we know that in this case, there's what is very much lacking is actually MDT and the whole, the in-depth discussion of the patient's problem at the very beginning. So is there in any way, like at the end of this session or your last few sessions, that we're going to have sort of like the continuation, or what is actually to be brought up as an echo from all these activities that we have done, whether we're going to have MDTs with the public hospitals, with the KKM hospitals, with those that have established MDTs. Not quite sure where this is actually really going. Yeah,
actually, maybe Prof. Aisha, you want to explain?
Maybe this year is the year of exploration and networking. Because when we do any implementation, it has to be phased. As what Dr. Kavitha said, it's a matter of time before the change takes place. But we have to be very realistic about how much we can achieve and how fast we can achieve it. So what we have is a big commitment actually from Ministry of Health in the City Cancer Challenge project, which is the increased capacity in MDT for breast cancer management. We have a whole group of project team members from public as well as private hospitals. I think I can give you the information in more detail later, but essentially this group has come up with an action plan that will be sustaining that project from City Cancer Challenge. So it will be actually hosted by Academy of Medicine, Ministry of Health, and of course we do have the ECHO project. So the ECHO project, we have signed an MOU with University of New Mexico. So we do have an ECHO account, and we will be migrating to what we call the iECHO. The iECHO is actually an app that will even help you track your CPD points, and that iECHO will access the networks that we have. But what we want is really service MDT. And actually, Dr. Vaish, she's actually I think she's still here. She's actually the lead for the MDT project in the City Cancer Challenge. So as you know, the outputs from the action plan project that was mentioned just now was one of the document is the best practice document for implementing MDTs. And the other one we already have in our city is our clinical practice guideline. What we want is to disseminate the CPG through our CPG champions from Ministry of Health, as well as help hospitals implement MDTs. But it's a bit difficult because a lot of hospitals like Hospital Serdang, they do not have all the specialties in one place. So we need to work inter-hospital networking. So Nani, both you and me and Dr. Teoh, we all come from the Ministry of Education hospitals. So in terms of service, is also not very seamless for referral to our hospitals. But we will have to find a way which is not under this project lah. There will be a project on how you finance healthcare, how people from private sector, especially the private sector, can actually contribute to the quality of care for the city. So I think we have to watch that space. But the main objective of this project is to provide service MDTs to improve the quality of care. And what will happen is in the public hospitals, and I think us in the universities, we can support. I think we have such fantastic radiologists, Dr. Aida is there, and then you have Dr. Fariza, and then Nani, all the lecturers, Dr. Teoh, we are all here. We can actually support our Ministry of Health colleagues if they need in terms of maybe input or, expertise. And even in Ministry of Health, we have experts in there, like Dr. Vaish, and then we have also Dr. Mutu. There's so many oncologists there. So I think what we need is just how we can find a way to work together. And we have to accept that there are challenges that we face in the city. So I think a lot of especially the general surgeons, I think they treat the bulk of cancers patients in the city, but they don't have the resources. So we need to help them. So that's all from me. Dr. Teoh dah tengok I lambat sangat lah. Okay, so I'll stop here. But Nani, I hope you understand lah.
Yeah,
So,
because as I can understand from Dr. Hati nowadays, as of now, they just ad hoc phone calls to say like Putrajaya Hospital. So it's like quite difficult for them.
Yes. So we hope to create this real service entities. But of course, I think this is a co-creation of pathways. And what Kavitha is saying about the integrated pathway, I think we need to work on that. And the integrated pathway is going to be a hybrid pathway because not every hospital will actually have all the specialties.
Nuraisha, if I can just say one word, and that is that hi. The MDT is the sessions that we are having here is basically to network, so that whoever is attending this knows that there are people out there that are willing to help, even in the private sector, that are willing to get online with you, organize a Zoom MDT, even if it's from Switzerland, and help you out with your problem. So I think the main objective here is you've got to raise your hand and ask for help, and then it definitely will come. Even if it's in imaging, if it's in getting a biopsy done, as one of the participants said, sometimes they come to private just because they can get their imaging and their biopsies done quickly, because that's the time lag for patients who go to the government sector. But once you've got the diagnosis of cancer, it actually moves very fast, and you actually can get your surgery within 2 weeks in most government hospitals once you've got the diagnosis of cancer. So I think the idea here is to network and to offer to those out there who can help you along the way, even if it's a difficult decision. I mean, there's really no problem. We can help you to even set up an MDT and have a Zoom meeting after office hours if that's what you really want. So even if you don't have
you are
and say that you need help, and we're all out there to help you anyway. Thanks.
Thank you so much, Dr. Patricia. Right, I think we shall wrap up this session because we have exceeded the